Hello everyone, my name is Sedar Ozturk and I would like to start with thanking organizers for allowing us to be a part of this well-organized event in here. I certainly believe that it's a well-organized and a timely organization because we have some common denominators in here such as vaccine hesitancy. And before presenting my presentation, I just would like to highlight our motto. Our motto is vaccines cannot solve problem. Vaccination can solve problem. If we cannot turn vaccines into vaccinations, it doesn't matter what I talk today about our vaccine or some other vaccine, because at the end, we need vaccinees, we need parents to convince the importance of vaccination. So what I would like to highlight, at least for a couple of minutes in the beginning of my presentation, I kindly encourage you to refer World Health Organization European branch website. They have very recently published a well-documented guideline against vaccine hesitancy. And if you want, during the break, during the coffee break after my presentation, I'm here to talk about, because I have a public health PhD, like my colleague Nur Aksakal from Turkey, and it's our devotion to vaccination rather than talking about individual brands. So having said that, my name is Sedar Ozturk. Again, I'm responsible a region called Middle East, North Africa, and Russia. It's a large region, like what we are discussing in here. I'm working in GSK. This is my conflict of interest statement. I'm a full-time employee in GSK. And today what I'm going to present, there's no intention to sell any vaccine in here. To be very pragmatic, to be very blunt about it up front. I'm here, I just arrived, like you, ma'am, yesterday, for discussion of the science. So what I'm going to present in the next 25 minutes, it will be based on currently available publicly disclosed data, and I would like to represent some of our findings and some of the interesting findings to be discussed with you. And there are 3 points that I would like to look for. First, I would like to again thank the previous speaker on pneumococcal disease, because basically you represented what I have already planned in here. It's amazing. You will see in the next couple of slides. I'm going to summarize the outline, why we still need pneumococcal conjugated vaccines for pediatric immunization programs. For most of us, it's no-brainer, I understand, but still, in some countries, we are facing difficulties. We are facing some hard things to do to convince parents, sometimes decision makers. And what should be expected from pneumococcal conjugated vaccine programs? And again, I will continuously focus on pediatric pneumococcal conjugated vaccine programs. And then at the end, I would like to summarize my presentation by providing independent reviews and recommendations. So based on this, again, this is the same slide, World Health Organization. For me, this is one of the most important slides that we have to discuss. Yes, invasive pneumococcal disease, it can be deadly, listed in here. And mostly we can see meningitis, septicemia, sepsis, and sometimes we might still see an invasive pneumonia as well. This is the invasive part, and well, basically originally, these pneumococcal conjugated vaccines in pediatrics, it's intended to prevent for this disease first. And then the second part, as highlighted with the previous speaker, non-invasive and mucosal part. And if you are asking me which part is easy to prevent with the vaccines, invasive one. Because the current level of antibodies, and it shows that it's enough for both vaccines to prevent invasive disease. But what about acute otitis media? What about sinusitis? Last time I checked out in EMRO region, you know better than me, Professor Shibul, antibiotic prescription due to acute otitis media is one of the costly items that we have to look for. Anyhow, so parking this discussion for the further discussions, I just would like to highlight that there are more than around 100 different serotypes, serogroups of pneumococci. And the last one last year is defined as 97th one, identified in last year, and then after I stopped tracking, because it's increasing in every month, they're identifying a new ones. And the issue is, it all depends on their polysaccharide capsule, and it's classified with the cross-reactive serotypes. What I would like to highlight in here, based on World Health Organization guidance, there are give or take 10 serogroups are responsible for most of the disease in the pediatric age group. And again, it represents the importance of pneumonia and meningitis and sepsis. Again, this was presented with the previous speaker. To go together with pneumonia and meningitis, account for approximately 25% of the overall total number of deaths in children under the age of 5. And again, this is global childhood mortality estimates for 2013. I'm not talking about ages ago. So in here, it represents that, I would like to underline again, both pneumonia and meningitis are major causes of mortality in children under the age of 5. So if we are still seeing this, what are the currently available pneumococcal conjugated vaccines for pediatric usage? First and the last time, I'm going to use 2 brand names, and then I'll continue to use generic names. First one is, and it contains 10 serotypes itself. It's called PHID-CV, pneumococcal conjugated vaccines conjugated with protein D from Haemophilus influenza non-typable ones. And then the other one, Prevnar 13, it contains 13 valents conjugated with CRM. And then if you're looking for this very recently, this is a new information from 2015, PHID-CV received a 19A cross-protection conferred by PHID-CV. It's indicated in Europe, and it's already included in the Saudi label as well. So following this, I would like to summarize the PHID-CVs, or 10-valent GSK's pneumococcal conjugated vaccines availability. This is summary. And this slide is the only one that I'm representing data on file. Other slides that I'm representing, it's all based on publicly available scientific data. And if you're really interested, I'm ready to share with you after my presentation. It's available in 117 countries, just with one difference in your presentation. Professor Nur, you said 32 plus 6. We just introduced in Italy, a new one, it's 39. As you can see, its majority is currently using PCV13, I agree, but the increasing number of countries, they are reviewing it. And if you're looking for the European countries, 12 out of 29 European countries, they are using Synflorix only. And if you're looking for the overall numbers, more than 500 million doses have been distributed. And give or take, this is an assumption, of course, over 140 million babies have been protected by Synflorix. So this is the summary. And of course, before discussing any products, we have to first look for safety. And this is coming from our clinical trial development program. As expected, it's also true for other vaccine as well, 13-valent vaccine as well, generally well tolerated. And the most frequent adverse event is the pain at the injection site and redness and swelling as expected. But again, at the end of my presentation, I'm kindly encouraging you, if you find out, and please provide the feedback, any adverse event that you might think about this vaccine as well. And this is a very busy slide. Let me guide you. This is a summary, and this is one of the differences between those 2 products currently available. PHID-CV is the only vaccine can provide you results from real-world data and the randomized control trial. What's the importance of randomized control trial in this context? Well, basically, it's timely, it's costly, but it provides you an ideal world outcome. And as represented in here, let me guide, there are 3 distinct groups of concentration of the concentrated diseases. First is invasive pneumococcal disease, and the second, let me use this one. Sorry. First one is invasive pneumococcal disease. And there are 2 different randomized control trials that have been conducted. First is in Latina, 3 countries, Argentina, Colombia, and Panama, more than 20,000 subjects. It's called COMPASS trial. And the other one conducted in FINIP, in the 2 different globally or geographical position. And this is the outcome related to invasive pneumococcal disease. Outcome, if we are looking for vaccine types, the 10 serotypes containing within the vaccine, it's 100%, both in Finland and Latin America. And if you are looking for, well, this was our idea, instead of looking for vaccine types, look for the impact on any invasive pneumococcal disease. It was 93% in Finland, FIN-IP trial, and it was estimated as 65% against any invasive pneumococcal disease in Latin America trial called COMPASS. Following this, I would like to switch to pneumonia immediately. In pneumonia, again, we are going to look for Latin America results and Finland results. In Latin America, COMPASS was primarily built up on bacteriological community-acquired pneumonia. It was a primary objective. But in Finland, it was a secondary objective. And the results in here, I would like to focus on WHO definition of community-acquired pneumonia, which is 25%, and bacteriological community-acquired pneumonia reduced 22%. Well, what does it mean? In here, we are talking about individual serotypes by saying vaccine types, all invasive pneumococcal types in here, but we are looking for definition of serotypes in here. But in pneumonia, it means that all possible suspected community-acquired pneumonia can be a part of this overall disease program and also this clinical trial, which means we are suspected that this should be most likely a bacteriological pneumonia due to a chest X-ray, fever, and some respiratory problem that identified by the doctor. And in Finland, if you are looking for, there are two different schedules in here, 2+1 and 3+1, is more than 40%. And then the acute otitis media, if you are looking for otitis media, the impact of clinical acute otitis media is 19%. Again, it might include the overall other bacteriologicals, but it reduced up to 20% reduction. And if you're looking for vaccine type clinical acute otitis media, reduction is around 70%. So what about the effectiveness against invasive pneumococcal disease? First, I'm looking for PHID-CV, GSK, pneumococcal conjugated vaccines. And again, as expected from randomized controlled trials, it's not 100%, but it's not less than 70%. There are different countries in here, Finland, Netherlands, Brazil, and Quebec. What about the other products currently available? It's Pfizer's PCV13 product, effectiveness in the real world after the registration. It's coming from, again, Canada, United Kingdom, Germany, and US. Again, as expected, not 100%, but more than optimal, is between 75 to 86%. So the question is, it's highlighted, and I would like to again highlight it, that I'm not aiming to compare these two products. It's not possible. Because scientifically speaking, there is no head-to-head clinical data so far conducted, so therefore one cannot say that this one is better than the other one. But what we can do in here, and this is the limitation of my next slide, I would like to focus on first, there are differences in the durations and design of the studies, and it doesn't allow us for a direct comparison. But instead, the next slide, what I'm going to do is to looking for the impact of these two available products on overall invasive pneumococcal disease, which is the current postulate, what we are aiming for right now, highlighting in here. Again, it will be a very busy slide, but let me guide you. In blue ones, it's coming from 13-valent pneumococcal conjugated vaccines, and the four green ones is coming from GSK's pneumococcal conjugated vaccine, PHID-CV. And again, if you are interested for the highest numbers, you can either go for United States with blue one or go Iceland with green one, and you can say that, okay, more than 90%. Is it the reality? No. So the reality between, let's be honest, the reality between and the lower impact and the higher impact, so if you can go, for example, in here, in France, 43% up to 92%. And if you are asking the setting, I would like to highlight, this is among, all researches have been conducted among children under the age of 2. They look for overall impact, overall invasive pneumococcal impact, and all have been conducted in pediatric immunization program, and they compare pre-data and post-data. They compare it, and these percentages are the reductions on the overall invasive pneumococcal disease. So what we can say as a summary of this very busy slide, very simple. Both vaccines are working similarly. They are acting as expected, and they are reducing overall invasive pneumococcal disease partially. And again, if someone going to say that GSK's vaccines is not working, I would definitely suggest them to go Chile, because it goes as low as 62%, or you can choose Iceland is 94%. But the reality is in between. I can call it as a confidence interval. This is my personal speculation, of course. And then 19A is one of the still debating issues, and thanks to Atif Shibil's presentation and publication as well, I believe, sir, you published that paper in 2016. And it shows that there's a difference between northern part of the Saudi Arabia and the southern part. But also in the both products, I can say one thing very clearly. Effectiveness is not solely determined by the composition of the serotype content of the vaccines. In the upper side, PCV13, it contains 19A in the composition. And the lower side, PHID-CV, it doesn't contain 19A. But thanks to cross-protective antigens inside of our composition related to 19F, these are the results, clinical outcomes. And based on this, World Health Organization, European Medicine Agency, they have granted us a 19A indication. But again, it's not 100% for both products. So this is the CHMP approval as of July 2015. And following this, almost all countries in my region, they have already received this 19A in their label as well. So this is an interesting finding. This is very new, published in last year. So how one can compare these two products? This is an interesting answer for this question. This is a very important question. It's an independent study. It's coming from Sweden. And Sweden is a unique country because we were expecting the outcome of this study for a long time, because they started with PCV7. I have the full publication and the slide deck, and I will definitely love to share with you. In the different color zones in here, they first started with PCV7, and then one decided to continue with PCV13. This is the darkest color, so I have some color blindness about that. And some orange ones, they have decided to continue with PHID-CV. And the green ones, they go mixed. So in this particular study, they look for ambulatory acute otitis media and the impact of the vaccination in that particular counties. So they started in the same country, in the different counties, and they compared the impact on acute otitis media. It's a retrospective study. Yes, there are some limitations. They look for pneumococcal conjugated vaccine impact on acute otitis media, children aged between less than 5, and the years that they follow from 2005 to 2014. They look for two different outcomes. First, ambulatory acute otitis media is outpatient setting. And the other one is acute otitis media requiring surgical intervention. So they look for these cohorts. They compare the difference between 2007 and 8 versus 2013 and 14. And of course, this is a limitation, because if you can extend the follow-up time, this might affect the results. But this is a very interesting finding that just published last year. And this is the result. In 2014, they discovered 25% lower risk of developing ambulatory acute otitis media in counties using PHID-CV versus PCV13. And again, in the same study, they found that 22% lower risk of requiring tympanostomy tube insertion in counties using PHID-CV. So the question is, these are statistical significant, but can we say that this is the great difference between? No, this is based on Sweden data. This is a comparison of different counties. And again, there is no big difference in here. I would like to highlight, this is a conclusion of the authors. This is an independent study. They are saying that no such difference could be seen for meningotomies or hospital admissions. But really interesting supporting studies that what is accumulating right now, like in Iceland, like in Finland, they discovered that at 22%, this is just published in 1 month ago in Melbourne in ISPPD Congress, they represented in Iceland in reduction of all antibiotic prescriptions up to 22% related to acute otitis media. And they are still using PHID-CV in their national immunization calendar. So what about pneumonia? Green ones are PHID-CV, blue ones are PCV13. Let me summarize this busy slide by saying that both of them are working beautifully. These are all coming from Latin America setting, yes, and there are different outcomes, because one is orange, the other one is apple, but if you are looking for the overall outcome, it's somewhat very similar. And what about nasopharyngeal carriage? There is one randomized control trial to compare outcome of nasopharyngeal carriage between those two currently available vaccines. And it says that PCV13 might have had a better outcome or larger reductions in nasopharyngeal carriage. Jury is still out, but in these studies, as a summary, from Iceland to Kenya, Fiji to Mozambique, it shows reductions in nasopharyngeal carriage as well. This has been either published as a manuscript or shared as a poster or abstract with the recent congresses. So again, this is my last point. I think I'm on time, right? Thank you, sir. These are independent reviews. I'm going to focus on 3 independent reviews and recommendations coming from, first is PAHO-funded review, systematic review. Second is an IVAC analysis, general systematic analysis, and the third and the last one, the latest one, World Health Organization SAGE recommendation. So this is a PAHO-funded review paper, represents an analysis, the impact and effectiveness of both vaccines in Latin America setting. Well, basically they reviewed more than 1,000 citations. According to their prescribed definitions, they analyzed further 22, and this is the outcome. They look for, as an endpoint, they look for hospitalizations, deaths due to invasive pneumococcal disease, pneumonia, meningitis, and sepsis. And these are the countries. They look for all, and then among these 22, Brazil, Chile, Argentina, Peru, and Nicaragua was the countries. And this is their author's conclusion. This is an independent review. They said that there is no evidence between those two vaccines currently available, and there is no superiority of one vaccine to other. Following this, again, this was in last year, published by Johns Hopkins University's International Vaccine Access Center, IVAC. They have conducted, behalf of US CDC, World Health Organization, and UCL as well, and also Agence de Médecine Préventive. They conducted a review among 14 databases, and basically they focused on January 2010 to October 2015, but also they have added the ad hoc additions through January 2017. One of the limitations in here, they didn't look for 3+1 schedule. They look for mainly 2+1 and 3+0. And they haven't conducted a meta-analysis due to heterogeneity of the data between those two products. So the question is, when they are looking for in here, they look for pneumococcal disease epidemiology, performance of both products, product supply and cost, and this is the outcome. This is the wording in their summary. It's more than 145 pages long, really detailed review paper, and there's a summary of it. You can easily download it in the web page. It says that current evidence doesn't indicate any added benefit with one vaccine over the other. If you're looking for in detail, they look for these individual titles, from immunogenicity to carriage, invasive pneumococcal disease impact to pneumonia, mortality to indirect effects. Well, again, I would like to highlight in here, both PCVs showed high efficacy against vaccine type disease. PCV10 showed cross protection for 6A and 19A, a European Medicine Agency label protection against 19A. No consistent evidence of efficacy of PCV13 against serotype 3. And as we know that serotype 3 was a complicated serotype for a long time for both vaccines, so it's confirmed with the help of this IVAC paper as well. So let me continue with the last recommendation coming from World Health Organization. It's SAGE committee recommendation, December 2017, and if I'm going to speculate, this is the shortest recommendation so far from SAGE, but when you are looking for the web page, they look a considerable amount of presentations from independent authors and presenters, and this is their conclusions. They look for 2+1 and 3+0 schedules in here. They identify that substantial impact from both vaccines with 2+ and 3+0. And their recommendation, you can start either dose schedule as early as 8 weeks. If you are using 2+1 schedule, minimum interval of 4 weeks and maximum of 8 weeks in primary schedule, and booster has to be conducted in 9 to 18. I know nowadays many countries, they are discussing to reducing the overall doses of pneumococcal conjugated vaccines. Most of the Gavi countries, they are using 3+0, and countries in Europe, majority of them, they have started to use 2+1. Even UK, they have announced their intention to go 1+1. Interesting enough, there is an ongoing study in Vietnam. They are looking for 2+0, 1+1 comparison of both products. And the first preliminary outcomes has been represented in Melbourne a month ago for both products, and the outcomes are very similar. And if you are interested about these developments, I can be freely sharing with these abstracts with you during the break. And as a conclusion in here, this is the important part, if we are looking for the impact of currently available 2 pneumococcal conjugated vaccines on overall invasive pneumococcal disease, there's no difference. And then in here, I would like to highlight that PCV13, it was indicated by World Health Organization SAGE committee that if there is a serotype 6C and 19A disease is prevalent, there might have an additional benefit with PCV13. This is their wording. And again in here, PHID-CV and both vaccines represent substantial impact against vaccine-type invasive pneumococcal disease, carriage, and pneumonia. So this is the summary of their recommendation. So based on these developments, what has been changed? Well, basically increasing number of countries and their NETAC or recommendation bodies, they started to recognize this difference by saying that these 2 products can be available for pediatric immunization program, from New Zealand to Netherlands, Poland to Finland and Sweden. And this is my last part. In next 5 minutes, I would like to focus on New Zealand. This is an interesting, and you can easily click on this. They have already established a really good and beautiful surveillance program. And you can click on this one. And this data, I mean, they decided to start PCV vaccination in 2008 with PCV7. Then they switched to PHID-CV in 2011. Then they switched to PCV13 in 2014. And then in 2017, last year, July, they switched back again PHID-CV. The question is, in switching from PHID-CV to PCV13 in 2014, it was related to numbers of 19A and their concern about that. And today, with the help of these next 2 slides, I would like to represent why they have decided to go back PHID-CV. And you can freely use this data and download it. It's publicly disclosed and well available. And this is New Zealand data, represents the overall number of cases, all age groups, invasive pneumococcal disease by quarter between 2010 and September 2017. And as you can see in here, there's a seasonality in New Zealand for invasive pneumococcal disease, as expected. And it might be linked with the influenza seasonal peaks as well. So you can see in here, there are peaks and then ups and downs. It's very similar. It continues the same with the PCV13 introduction, as well as in PHID-CV. But if you are looking for different age groups, so this is the total invasive pneumococcal disease, we colored down, and you can look for children under the age of 2, age group between 2 and 4, and the above 5 years. So these are representing in here, and these are the years. And if you are looking for in here, especially the children under the age of 2, and again, if I can go back, 2011 and 2014, 2011 and 2014. Again, surveillance programs, Professor Shibul and Professor Ziad Memish, they know better than me, of course. It's not a snapshot. It's not a photograph taking. It's about video recording. Because if you are taking your snapshot in here, taking this one, and comparing this snapshot with this one, of course, it gives you some unrealistic comparison or expectation. Or I can take this one and compare with that one. But these snapshots cannot represent the real world data. What we need in here, a continuous surveillance program. So they have conducted the same, and in here I'm highlighting the matter of concern for New Zealand, as represented with the previous speaker, 19A. Would you be able to find out the difference between those 2 products? And I have highlighted in here the PHID-CV introduction, again PCV13 introduction. And as you can see in here, these are the age groups, and this is specific to 19A invasive pneumococcal cases in New Zealand. So there's no difference. Basically, of course, there are some similar differences, but the question is, there is a repeating pattern in here. So after diagnosing this, New Zealand authorities, they have decided to open up a tender, and after getting this, PHID-CV reintroduced in 2017, July. So some countries have decided a similar context, starting from 2012 to 2017. These are the countries. And again, since I have a public health background, I would like to highlight that not all of them as if one company is winning. Of course, this is a competition, but healthy competition can reduce the overall cost. For example, Morocco, they have decided to introduce rotavirus vaccination. They are using Rotatec, by the way. And then New Zealand, they have decided to invest that amount of money for vaccination of, I believe the previous speaker asked this, whether it's a vaccination of boys or girls. They have already started at that time in New Zealand for girls vaccination. So with the help of this saving amount, they invested on boys vaccination and varicella. So conclusions. If we are having this presentation 10 years back, we will only talk about immunogenicity because at that time, that was the only currently available data based on this. And we were counting on serotypes in the individual country, and we can speculate what will be the possible impact of that particular vaccine in the country. This is no longer true. We passed that time. And as represented, non-vaccine type increase, overall vaccine type, overall impact are still important valid point for us. And if we are representing this, there is no difference between those two vaccines. There are two available products. And based on this evidence, immunization bodies are considering increasing number of immunization bodies, considering both vaccines currently be available for their NIP programs. And again, this is our safety our post-marketing safety results shows what we have already seen in the randomized control trial. And please, this is our adverse event reporting line. This is the email and our colleagues on the outside. Please share any adverse event. This is part of our SOP, I have to highlight. And this is our label in Kingdom of Saudi Arabia. And at the end, I know what to say. Shukran for your attention. Shukran for your real attendance for today's call. Thank you very much.